I'd like to share with you this case, which was a rather unusual presentation of a patient with a hypermature cataract. So this was the case. A patient with a hypermature cataract. There was an obvious phacodonesis. The pupil was a 5 mm non-dilating pupil, and the visual acuity was down to a perception of light. We performed a preoperative ultrasonography which revealed a normal posterior segment. Let's start with the surgery. The preliminary steps, that is, creating the 2.8 main incision and the 2 paracentesis incisions, along with the staining of the anterior capsule, was uneventful. The anterior chamber is now filled with a cohesive viscoelastic, keeping in mind that this is a hypermature cataract. I now attempt at trying to dilate the pupil slightly further by using the Y-shaped hooks to perform a stretched pupilloplasty. I am able to achieve a further dilatation of the pupil, and that is visible here. I now proceed to performing a capsulorhexis. Mentioned here are all the various reasons why creating a capsulorhexis can be rather challenging and often unpredictable in a hypermature cataract. I make an initial nick, I get some of the fluid that flows out, I reform the anterior chamber, and I now attempt to proceed to complete the rhexis with using an intraocular forceps. What you will notice in the following part of the video is rather interesting. As I proceed to create the capsulorhexis, I find the nucleus within the bag start to vanish. Suddenly, I see a clear space, and I can see this clear space gradually increasing in size. And please note, I do not see a corresponding loss of the liquefied cortex in the anterior chamber. Nonetheless, I proceed to complete the capsulorhexis with the intraocular forceps. So here we are. At the end of the capsulorhexis, we see a significantly large gap in the nucleus. Let's move to see how we manage this case further. I now proceed with the bimanual irrigation aspiration of what appears to be this liquefied cortex. And rightly so, most of the cortex starts to get aspirated from within the capsular bag. The question now is, where is the nucleus? And here it is. This tiny nucleus amidst an entire capsular bag filled with liquefied cortex. This nucleus is aspirated by the irrigation aspiration itself, and this is followed with the removal of the rest of the cortical material. What you will now see is a fibrosis of the capsular bag in the mid-periphery in the superior temporal quadrant. Because of the preoperative phacodonesis and my lack of clarity whether the bag is subluxated or not, I choose to perform a viscofluid exchange. I then proceed to introducing a CTR in the capsular bag with a hand-on-hand maneuver. This is with a view to achieve an equatorial stability of the capsular bag should it be subluxated. And finally, the introduction of a single-piece monofocal IOL within the capsular bag. This is followed by the removal of the excessive viscoelastic from the anterior chamber using irrigation aspiration. And finally, the stromal hydration, which marks the end of the surgery. This is the end result that we achieved. Thank you.